So I have the pleasure to introduce Thiri. She's a sophomore at UC Berkeley, and she's majoring in public health. She also began writing Yelp reviews in the beginning of the summer and is working towards becoming Yelp Elite member. Yeah, so good luck, Thiri. You got this. It's in the bag.
Okay. Hi, Christian. Oh, sorry. Thanks, Christian, for introducing me. Hi, everyone. My name is Thiri, and my project is based on antibiotic use in children with urinary tract infections. And my mentor is Prachi, who is with us today. Oh, okay. UTIs are one of the most common infections in children, and UTIs are defined by 10,000 colony-forming units per milliliter for samples obtained by cath, 100,000 for samples obtained by clean catch, and they're caused by gram-negative bacteria, the most common being E. coli. Antibiotic resistance is significant because there are a lot of germs and a few are resistant to antibiotics. So when antibiotics kill bacteria causing illness, they also kill good bacteria protecting the body from infection. The antibiotic resistant bacteria grow and take over, causing things like C. difficile infections, and some bacteria give their antibiotic resistance to other bacteria, causing more problems faster than new antibiotics can be made, spreading in hospitals and high density areas, increasing deaths. Because antibiotics are given empirically and before a confirmed UTI, we hypothesize that 20% of our patients without a UTI will be inappropriately prescribed antibiotics. To test our hypothesis, we conducted a retrospective chart review of pediatric patients admitted to the UCSF Benioff Emergency Department from 2019 to 2021, and we defined a UTI as a colony count of greater than 100,000 colony-forming units per milliliter of gram-negative bacteria, and we want to analyze the number of inappropriate antibiotic prescriptions for children without UTI. So these are our results and the demographics of our patient population. 53% of our patients did not have a UTI, while 47% did, and 75% of our patients who had a UTI were female. We also had a very diverse patient population where 70% of our patients were Hispanic or Latino, followed by the white or Caucasian and Black or African American percentages. So getting into our results, we found that 89% of our patients without a UTI were prescribed antibiotics in the emergency department, which is shown in the red right here over the span of 3 years. And that 89% resulted in 695 unnecessary days on antibiotics, which is almost 2 years. And this should be a wake-up call for UCSF Benioff to establish a more involved antibiotic resistance program. But a start of that is just identifying the problem that we have. So we have concluded, and this is a summary, that 53% of our pediatric patients who were admitted into the emergency room did not have a UTI, but 89% of the patients without a UTI were inappropriately prescribed antibiotics for an average of 7 days, which resulted in an excess accumulation of 695 unnecessary days spent on antibiotics. So aside from decreasing antibiotic resistance, these are the future steps of our project. We want to reevaluate the current sample size by assessing the method of collection to redetermine the UTI diagnosis status and adjust the data accordingly. We also want to see why some patients had no inflammation despite having significant growth of uropathogen-associated bacteria. We also want to analyze the relationship between COVID-related stress and inappropriate antibiotic prescription in 2020. And lastly, we would also like to decrease health disparities by calculating the likelihood of UTI and inappropriate antibiotic prescription. Ultimately, we seek to increase antimicrobial stewardship efforts at UCSF Benioff to limit our impact on antibiotic resistance following the One Health model. So thank you to the Berkeley SSRP staff and community for introducing me with such a great speaker series and introducing me to my mentor Prachi, who's with us today, who gave me the unique experience of being a scientist, and my SEO scholars, mentor, Shira, who I think is also here today. She encouraged me to apply this program when I didn't think I could get in, and she believes in me, and that's why I'm here. And one last thank you, because David hasn't put his hand up yet. One of my friends is here today. Her name is Leilani, and we went to our first research symposium together last semester, and we were thinking, oh, maybe in 3 or 4 years, like we'll be presenting our research, but we're here today, and well, she's listening to me and she's doing her own research project. So that's just really cool. So if anyone has any additional questions, you can let me know.
Fantastic, Thiri. It's great to have such a big supporting group behind you here too. That's wonderful. Really interesting project and so relevant to clinical care for sure. It looks like Erica's got a question for you to start off with.
Hi, Thiri. I loved your presentation, and I feel like these statistics were really shocking. So I know you can't exactly say why this discrepancy is happening because it hasn't been studied, but what are some theories you have as to why this is happening?
Well, I think part of it is because we give the antibiotics before there's a confirmed UTI. So me and Prachi we're actually working on like better diagnoses. So like trying to see if like if inflammation is correlated with it, if the method of collection is correlated with it, and that's what we're planning to work on during the fall. And I think because there's like a 2-day discrepancy before you get confirmed UTI, you're most likely to just give the patient antibiotics because they're also really young, and so issues like that.
And I also have a follow-up question. What about with women? Because it seems to be happening to women more often.
Yeah, I would say that based on what I've read, most of it I think is anatomy. Like we just have a different like anatomy in comparison to males. So yeah.
Thank you.
Mm-hmm.
Amy, you still got a question?
Yeah, I kind of had the same question, so it was answered, but I'll also ask, do you know of any other like defining factors of a UTI other than the colony count of greater than, I think it was 100,000, that could possibly be leading to the prescription of antibiotics?
I don't know the full answer to that, but I will say a lot of it is dependent on the symptoms. And that is what Prachi has said. I don't know if Prachi wants to chime in.
You did great. So I didn't want to chime in. But it's a little bit of a two-step process. So when somebody comes to the ER and they have a fever and they're like, let's say they're a baby, you don't necessarily can ask the baby, is like, does it hurt when you pee or when you have a wet diaper? So oftentimes there's a method where we would collect the urine sample and then send it to the lab. And then there's usually a delay of about 24 hours or even 48 hours where that lab will tell us, like, is there bacteria in that urine or not? And what happens as the baby is doing well or have a little bit of fever, they will go home with antibiotics and somebody will have to follow that lab that was sent. And I think there's a misstep in terms of our ED and following all those labs that don't have bacteria, and yet the baby or the child still went home on 7 days of antibiotics. So I think a lot of that overuse of antibiotics is in that 1 to 2 step process. I hope that makes sense. And generally UTIs are more common in females than males.
So Thiri, if it seems like the problem is in the delay in the laboratory test, or at least a big problem, is there any way, did you guys talk about this in your group about expediting the results from the laboratory test, or is it really dependent on growth of the bacteria, and so you can't get the lab result back quicker?
I think from Prachi's verbal cues, it is dependent. Oh, I think
Yeah, it's
sorry, Amy.
it's right now it's a manual process. So it's like the when that sample goes to the lab, somebody takes it, inoculates it on these agar dishes that I did have the pleasure of like sharing that with Thiri. We went down to the microbiology lab and saw it, but it's a manual process where then somebody would daily look at those agar plates or culture plates and see like, is there bacteria there or not? We have come very far in terms of our diagnostics and rapid diagnostics and other things, but especially in uropathogens and UTIs, it's still very much a manual process.
Interesting. That's fantastic. Well, really interesting data Thiri, and look forward to seeing where this goes in the future and whether or not it's going to affect care at UCH Oakland. So nicely done.